Good day, and I hope you are fine. Thank you, Dr. Mazen, for inviting me to online conference. My subject today will be about the CBCT imaging in endodontics, and during this presentation, I will show you 14 causes to use CBCT in endodontics. The first cause we use CBCT, it will provide information about teeth with complex morphology. You can uh, look at this case here where we need more information about such anatomy. So this lower second molar, it shows uh, two roots, but we need additional information about the configuration of those roots. So once we take CBCT, it will show us the C-shaped canal, which will enable us to clean shape and predictable obturation of such morphology. This is called dense indent. So this dense indent, we need to know how much the tooth inside the main tooth is big or small, how much it's away from the main canal. So we need additional information. Because of this, we take the CBCT. The second cause is the CBCT will provide information about types of canals. So while we are looking at this tooth, we can know with using CBCT, the coronal part has three canals which join to exit in one foramen. That means I will prepare the main canal, then I will search for the joining point of the other two canals and clean them accordingly. So this will be the final result. Another cause, CBCT will provide information about canal curvature. If you look here at this tooth, you can see we are dealing with acute curvature. So we have to take care while using our files or rotary files. And another thing, this CBCT will give more information about number of canals. We are dealing here with two canals. So we have to take care while we are dealing with such tooth. The fourth reason for using CBCT, it will provide information about location of foramen. So when you look at this lateral lesion here in this tooth, you have to ask yourself why this lateral lesion occurred laterally, not apically. That means I need additional information. When we take CBCT, you can see here the foramen exists laterally. So when we prepare the canal, we have to know we will not reach to the apex. We will reach 2 or 3 millimeters from the apex till the exit of the canal, which is here. You can see this exit. When we look at this premolar here, we have a lesion and it looks like a normal tooth, but when we take CBCT, you can see here the canal ends 5 millimeter from the tip due to external resorption. That means if we take regular working length with the file till the apex, we will be out of the canal. Our real working length is 3 millimeter from the apex, which equals 17 millimeter instead of 20 millimeter. I will use a BC sealer and I will place my obturation 3 millimeter from the apex. I will consider this as open apex. And we could not know all of this without the CBCT usage. CBCT will provide information about the degree of calcification. If you look at this tooth here, you can see the shadow of the canal, but out of sudden you will see this canal disappear. That means something happened inside the canal, but I could not know what was happening inside. So let's take CBCT. CBCT will show us a pulp stone inside. And when we see pulp stone inside, that means I need ultrasonic tip. The regular files will not be able to remove such stone. So ultrasonic tip will enable us to remove the pulp stone and to enable us to enter inside the canals and clean them. When you look at this central incisor, which had a trauma 3 months ago, and compare it to the neighbor tooth, you can see the shadow of canal starts maybe 7 or 8 millimeters from the tip of the incisor. So I'm not feel comfort with this tooth. Let's take CBCT. CBCT will show us this tooth has starting calcification in comparison with the neighbor one. If we wait more about this calcification, it will calcify the whole canal and will block it. In this case, I prefer to go and make root canal treatment before calcification occurred completely, and by the way, the tooth start discolored. CBCT should be used for diagnosis in patients who present with non-specific clinical signs. This patient, he visited several dentists, and every time he claimed he has a sort of discomfort. When they take X-ray, they can notice a shadow of a circular thing inside the tooth, but they could not imagine what's happening inside. So when he came to my clinic, I suggested we need additional information. So let's take cone beam. Cone beam showed me excessive amount of sealer, while his previous dentist made a root canal treatment, and this sealer went buccally and apically and caused discomfort. So what I suggested, I will refer him to a periodontist to make a curettage, and this case was referred to that periodontist. CBCT has the ability to detect small areas of periapical pathosis prior to being apparent on 2D radiograph. When you look at this X-ray, that patient, he felt discomfort, and I always recommend when your patient feels pain or discomfort and in the X-ray you could not see anything, that does not mean the patient is free of pathology. That means the periapical X-ray showed us no periapical lesion because it did not appear yet. But if we take CBCT, we can see the lesion inside because CBCT imaging detects 17% more teeth with periapical bone loss than conventional radiograph. So, starting of today, when you have a patient who claims he has pain, you could not detect anything in his X-ray with the 2-dimension periapical X-ray, think to take a 3-dimension X-ray or CBCT. Another case here, with the regular X-ray, you could not see anything. With the CBCT, you can see a huge periapical lesion, which justifies root canal treatment. Another cause of usage of CBCT, it will provide information about missing canal. If you look at this X-ray here, you see good root canal treatment, but we have a lesion in the distal root. Why it happened, we do not know. Let's take cone beam. Cone beam will show me there is a missing mesiolingual canal, distolingual canal, which needs retreatment. And this distolingual canal, you can see it in the red line here. By microscope, we can detect where is this canal, and we can redo this canal and we can fix it. when we fix it, we have to retreat all canals here, and you can see the follow-up here after a few months or 4 months exactly, and you can see healing started. Look at this here. We have this premolar. The X-ray is good, but we have periapical lesion. Why this periapical lesion occurred? Let's take cone beam. Cone beam showed me a missing root. With this missed root or missed canal, periapical lesion occurred. So we can here look at the CBCT in the 3 dimensions. You can notice here this premolar in several views, buccal, axial, and sagittal. And you can notice here we are dealing with missed canal. So now we know the diagnosis. Let's go and let's make our treatment accordingly. And by making retreatment for the whole canals, we can see here we have missed canal and we have lateral canal. So let's make follow-up. This is the case where we started and we finished here. After 1.5 year follow-up, you can see here the healing occurred. Look at this molar here. With this molar here, I noticed we are dealing with large mesial root. So I need additional information. With the cone beam, I can see here in the mesial root, we are dealing with 3 canals, mesiobuccal, mesiolingual, and median. In the distal root, we can see here distobuccal canal and distolingual canal. And we can verify this by using microscope, which showed us 3 canals mesially and 2 canals distally. So we have to clean shape all of those canals, and of course we have to fill them, and you can notice here from the final X-ray. The main failure of upper first molar is missed second mesiobuccal canal, and we can verify this by looking at the CBCT. CBCT here will show me we have a missed second mesiobuccal canal, and we know exactly where is it. So we have to go, and with the microscope we can detect exactly where is the second mesiobuccal canal, and then we can go and make retreatment for all canals and fill and clean the second mesiobuccal canal, of course. The 9th cause of usage of CBCT is to detect of a fractured tooth. CBCT imaging seems to be generally advantageous in the diagnosis of horizontal root fracture. So if you look at this case here, this patient suffered of pain. When you take X-ray, the root canal, it looks fine, but I need additional information. Let's take cone beam. You can notice here we have horizontal fracture in the palatal root, and this tooth is for extraction, unfortunately. But what about vertical root fracture? Vertical root fracture here, X-ray alone is not enough to make a definitive diagnosis for vertical fracture. According to Patil, current evidence indicates that vertical root fracture cannot be detected with the CBCT. So we could not depend only on the CBCT to make a definitive diagnosis for vertical root fracture. We have to think with the clinical examination, and I like to remind you we usually have 3 main significant signs for vertical root fracture. We have cervical sinus, we have deep long pocket, and the lateral radiolucency in the X-ray. But however, the cone beam will show me a bone resorption associated with vertical root fracture. You look here, we have lateral radiolucency. If we take cone beam, we can see here we have this bone resorption in the lateral region. We can verify with the microscope. You can see the crack inside the root, so we reach to a diagnosis of vertical root fracture. If you look here at this tooth, you can see here with the cone beam we have a lateral radiolucency along the whole wall of the whole root. Another usage of the cone beam will provide information about dentoalveolar trauma. This is a patient who had a trauma a few days ago. He felt discomfort. We want to check what happened on those anterior teeth, so we could not detect anything in the periapical X-ray. While with the CBCT, you can see here at the apical region, we have a fracture due to trauma. If you look at this traumatized tooth here, if you need to know more information, let's take the CBCT. CBCT will show loss completely of cortical bone for this central incisor. That could not be happened without the CBCT. So let's see another usage of cone beam. Cone beam will provide information about external and internal resorptive defect. Nowadays, I could not imagine making a diagnosis for such resorption without the cone beam. Is it internal or external? And why we have to know internal or external? Because if it is internal, I go for conventional root canal treatment. If it is external, I have to use MTA to repair the defects. So here we have to verify this is internal resorption. So I will go and use just getaperca and sealer to fill the whole space. But what about this? Here we have shadow. We don't exactly know this is internal or external with the periapical X-ray. So we will go for more advanced imaging. More advanced imaging, that means I need the CBCT. CBCT here show me we are dealing with external resorption. Another thing, if you look carefully here in the mesial root, we have radiolucency. But what is this radiolucency? Is it internal or external resorption? I could not know easily. Let's take cone beam. Cone beam will show me we are dealing here with external resorption. If you look at this tooth here, we have impacted premolar, which caused resorption of this lower first molar. So it's obvious the mesial root here, we have resorption, external resorption. But what about the distal root? Are we dealing with external resorption or no external resorption? The premolar superimposed the mesial root, so it's not obvious what had happening under this premolar. So let's go and take cone beam, and this is a view, buccal view of the cone beam. It will show me we are dealing with resorbed mesial root, non-resorbed distal root. The length of the distal root is 18 millimeter. The mesial root is 12 millimeter. So we will go for the mesial root, and we will make regular treatment with the getaperca while in the distal root, while in the mesial root I will place MTA or bioserum. I will consider it as open apex tooth. Cone beam helps us in making a diagnosis for perforation. If you look at those two anterior teeth, in the periapical X-ray, we could not see anything strange, but with the cone beam, you can see here the first tooth has perforation and the second tooth has also perforation due to bad alignment of bear which caused this perforation. What about this tooth? I don't feel comfort about this forcation area. I need additional information. CBCT will show a massive perforation at the forcation area. What about this here? We have radiolucency laterally. What happened here? Let's take cone beam. Cone beam showed us a perforation in this area due to incorrect usage of the bear. What about this tooth here? It sounds innocent, but actually it is not. Let's take cone beam. Cone beam showed me a perforation in the floor of the pulp chamber, which went to the periodontal ligament. We can verify this with microscope. So now we know we have to make root canal treatment for other canals. Then we will apply MTA to seal the perforation, and this will be the final result of my treatment. Cone beam will help us also in managing broken files. We can see with the periapical X-ray this broken file. I need additional information. I need to know in this root how many canals we have. We have 2 canals. So are those 2 canals joining? Yes, we can see 2 canals joining in one exit. So if I go and make bypassing, I can reach to the end and bypass this broken instrument. What about this root? I could not remove this broken instrument. It is so long. I could not bypass. So what is the most important here to know? Is this broken instrument in the mesiolingual canal, mesiobuccal canal? Does the mesiolingual canal joint and have one exit? If yes, I will bypass or I will go from the mesiolingual canal, then I will seal the canal, then this broken instrument will be incorporated in the final obturation. So let's take the cone beam. Cone beam showed me the mesiobuccal and mesiolingual, they are joining in one exit or one foramen. So because of this, I will go from the mesiolingual canal, prepare it completely. I will leave the mesiobuccal canal, which has broken instrument, and this is the final obturation. Nowadays, we have what we call modern approach to manage calcified canals. In this modern approach, we are dealing with such a tooth. We have a huge periapical lesion, and we have this perforation inside. So to manage such a case, we need additional information. First, we need to know the size of periapical lesion, the site of perforation. Then I will make my plan to do the following. The part under the perforation will be filled with the getaperca. I know exactly the length of this part because the CBCT will give you exact measurement. I know where to place MTA in the resort part. So now I will calculate exactly those measurements. Then I will go for the application. I will place under the resorption the getaperca. Then I will place the MTA, and this is the final result after about 1.5 years. Another case, we are dealing here with calcified canal. I need to know where is exactly this calcified canal. I want to know how much it is away from the other main canals. So this will enable me to use the ultrasonic tip to place it inside this calcified canal and find the orifice and enlarge it. So let's take cone beam. With the microscope, I could not see any orifice. So I will use the calculation with the cone beam. Cone beam showed me those numbers. It will tell me the mesiobuccal and distobuccal, the distance between them is 1.6 millimeter, and they are away from the palatal canal with 4.2 millimeter. So I will take those measurements and then I will apply them inside the tooth. I will use the ultrasonic tip to enter at the point which we measured. Then I will enter it. Then I will enlarge it. Then this is the final result. Look at this calcified tooth here. This tooth showed me central incisor with calcification. And we know from the cone beam the exact length of the root, it's about 23 millimeter. The width of the crown, it's 7 millimeter. So to enter inside this canal, I need to place my file exactly at the middle, which is 4 millimeter. I need another thing. I need to know the angle where we can enter inside the canal. So let's measure the angle. It's 56 degrees. Now we will take those measurements and apply them for the natural teeth. This is the natural teeth here. I will take my pen and make those lines. The first line is the longitudinal line, which is 23 millimeter in the middle. Then the half the area of the distance of the crown, which is 4 millimeter. Now I need the angle, which is 56 degrees. I will take a file, active tip file. Here I used Hero. Then I will go directly to the canal. So let's go with this file inside. So this is the final result. Then I will prepare and I will clean and fill the canal. So I have a home message as conclusion. When you feel you are confused, lost, unclear, disoriented, you need additional information, you need to know more about this tooth, and you could not go further without knowing more information, my advice is so simple. Please take CBCT. CBCT will show you additional information which you need. Like this tooth here, I need additional information. With CBCT, it showed me we are dealing with a difficult tooth. So think twice before entering inside such teeth, and think always when you need additional information, take CBCT. Thank you very much for inviting me. Thank you, Dr. Mazen, for your effort, and I hope you will enjoy the other lectures. Thank you.